name is Matthew Menendez with White Plume. Appreciate your time this morning. Again, this webinar is designed for ophthalmology practices. We're going to be talking about ICD-10, physician productivity, and the revenue cycle, trying to give you some real practical strategies that will help you be successful. Let me run through just quickly our goals for today, what we hope to accomplish over the next 45, 50 minutes. I'm going to start with some background information on ICD-10. Now we're going to take a bit of a different approach. I'm sure everybody is familiar with at least what ICD-10 is. So what we're going to start with are what makes ICD-10 difficult? What makes it uniquely difficult here in the United States? Because there are some things that our government has done that makes this particularly challenging. One of the things that you'll hear a lot of people say is a lot of the other World Health Organization countries have already moved forward with ICD-10. The United States is one of the last countries to adopt ICD-10, and that's true. But there are some things that make this uniquely challenging here in the United States, so we want to take a look, understand what that is. I'll also share with you some mistakes we see other practices make. A lot of organizations, a lot of physician practices are behind in their planning on using these summer months to try to catch up and get ready. So I'll share some of the mistakes we've seen other ophthalmology groups make, so hopefully you can avoid making those mistakes over the summer. The last thing I want to do from an introductory perspective is to dispel some of the myths around ICD-10. There's a lot of bad information out there. Some of that is maliciously spread, others are probably unintentional, but we want to soothe some of your anxiety around ICD-10 because it's not as bad as a lot of people think. We're going to shift from that into understanding, giving you some tools to help understand what the impact is to your particular practice, to your providers, to your staff. Where are the places that are going to be difficult for you? Where are the places that are going to be a bit easier? So that you can make sure you're focused on the right areas. Now, you will hear a couple of themes throughout our time today. The first thing we're going to focus on is physician productivity. If your doctors are not able to take care of patients, nobody else in the practice is doing that. If your doctors aren't able to generate revenue for the practice, there's usually not a lot of other people in the practice who are doing that. And generally speaking, if they're not doing those two things, they're not going to be happy in their day-to-day work. And if our doctors aren't happy, nobody else is going to be happy either. So we've got to take care of our doctors first and foremost so they can take care of our patients. But you'll also hear me talk about the revenue cycle because we have to get paid for those encounters. You've got to get paid for those visits. And you've got to make sure that you have the right codes in order to do that. And that's another theme that you'll hear throughout our time today is the difference between ICD-10 compliance and ICD-10 productivity. A lot of people mistake ICD-10 as a pass-fail course in college, right? You want to do just enough to pass, but there are no bonus points available, right? That's not how it works. There will be some practices who are well prepared for ICD-10, who will thrive during that transition, and there will be others who are not. There will be some practices who have understood the implications to their workflow and made necessary adjustments and can be successful in ICD-10, both for their physicians and for their revenue cycle. There will be others who struggle with that. I want you to go into that with both eyes open so that you can make a conscious decision, right, rather than just the default mode of aiming for ICD-10 compliance. I want you to think about what the goal is for your practice as we go through our time today. I'll make sure that I leave plenty of time for questions and answers towards the end for those of you who are just joining us. If you'll look at the GoToWebinar control panel on the far right-hand side of your screen, you'll see a questions section that you can use to request follow-up information, to ask any questions that you may have. I'll try to get to as many of those as I can at the end of our time today. So let's jump in. What makes ICD-10 uniquely difficult here in the United States? And the first issue is it's a one-day conversion. This is not unique to the United States. A lot of other countries have a one-day ICD-10 conversion. What makes ours unique is that Thursday, October 1st is not our first ICD-10 conversion date. Right? That's something that has been delayed 3 times already. Twice by Congress, twice by CMS, and then most recently, last spring by Congress. And that's what makes ICD-10 difficult for a lot of practices, because there's not a lot of clarity on that ICD-10 conversion date. That's what makes it tricky. That's what makes it difficult. It's like the story of the boy who cried wolf. Right? Everybody remembers this story. The government has lost their credibility, just like the boy in the story, on this ICD-10 conversion date. So you have a lot of practices who aren't prepared. Rather than taking the necessary steps to be prepared, they're hoping that it's going to get delayed again. And if you remember at the end of that story, when the wolf actually comes, who pays the price? It's not the boy. It's the sheep and the owners of the sheep. For practices who are not prepared when ICD-10 arrives, it won't be the government who suffers. It'll be the practice and their providers and their employees and ultimately their patients. And that makes ICD-10 very difficult for administrators, for billing managers, for project managers, getting the rest of your team on board when there may be people that are hoping or thinking that ICD-10 is going to get delayed again. That's a very difficult place that a lot of you probably find yourselves in. The next thing that makes ICD-10 so difficult here in the United States is that it's a big change for physicians. And yes, it was a big change for physicians in other countries as well. What's different about that here is our doctors are not government employees. They cannot slow down. They cannot see fewer patients. In our fee-for-service world, they're paid based on their productivity. They're paid based on their volume. They cannot slow down and see fewer patients as a result of an unfunded mandate like ICD-10. The other part of that makes it difficult, again, for administrators and billing managers and project managers is that most physicians are not interested in ICD-10. They don't have the time to spend to get educated on the front end. So how do you prepare them to be productive in ICD-10 when they don't want to invest the time up front? That's a difficult challenge. They didn't go to medical school to be a coder. So we're going to talk about some strategies that you can put in place to help them learn quickly, but still produce the right outcome. And this last point is what I think is most difficult about ICD-10. A lot of practices are treating ICD-10 like all of the other government intervention we've had over the past 6-7 years. Right? We've been through e-prescribing and PQRS and meaningful use. And all of those were government programs. All of those were optional programs. They all had incentive payments tied to them. They were Medicare, Medicaid only. And there was the threat of the penalty down the road. None of those things are true with ICD-10. ICD-10 is for all of your payers, not just your government payers. ICD-10 is mandatory, not optional. ICD-10 carries no incentive and an immediate penalty if you're not successful with it. There is a lot at stake if you are unsuccessful in ICD-10. And it's not just about getting claims out the door with ICD-10 codes on them. You're still going to have to jump through the hoops and hurdles from the payers in order to get those claims paid correctly. So yes, ICD-10 is going to be very, very difficult for practices, particularly those practices who are unprepared. Now, I do want to share with you some of the mistakes that we've seen practices make. So maybe you can avoid some of these mistakes if you're preparing over the summer. The first mistake we see people make is the wrong assumption that ICD-10 is just a coding project. Right? I've got a coder, maybe I've got a biller, Maybe this is some of you. They're responsible for ICD-10. They're going to go to training classes. They're going to go to the boot camp. They're the only one in the office who really needs to know this stuff, right? And that's partially true. Yes, it's a big change for coders. Yes, it's a big change for billers. Yes, they should get certified. They should have training. They should have practice. They should dual code if possible. But they're not the only ones in the office who are going to have to adjust to this. That's only part of a successful strategy. Another mistake I see a lot of practices make is the assumption that ICD-10 is really mainly an IT upgrade, right? You see this on every ICD-10 checklist. Talk with all of your vendors. Talk with your clearinghouse, your practice management, your EHR vendors. Understand what version you need to be on. Make sure you're on that right version, right? Again, all of those are good recommendations. But you've got to go deeper than that. It's not just about being on the right version. You need to understand how that version works. You need to understand what workflow changes it will require. You need to understand, does it fit into your workflow today? Is that something that your providers will be able to do? Is it something that your coders will be able to do? How many extra steps will it take? How much extra time will it take? That's why you've got to go deeper. It's not enough just to ask your vendor, will you be ready? You need to understand how it works. And that's why we recommend looking at ICD-10 as a strategic initiative. And that means getting your management team involved, getting your doctors involved. That doesn't mean they have to be in on every meeting, but they need to understand the risks associated with ICD-10 for your practice and what strategies you have in place to mitigate those risks. And again, what we're going to focus on are the two biggest risks for an ophthalmology practice is, number one, a decrease in our providers' time, or decrease in our providers' productivity. We can't have them seeing fewer patients. Can't have them spending more time on administrative tasks because of ICD-10. And the other part is equally important, is a decrease in revenue cycle efficiency. And when I say revenue cycle efficiency, what I mean is how many people, how many labor hours does it take to collect your cash flow? Because if you require more people to collect the same cash flow, that's a bad outcome. If you keep your labor hours constant, but it takes you longer to collect your cash flow, or you collect less cash flow, again, that's a bad outcome that we want to protect against. You've got to have that process well tuned. Right? Now, yes, ICD-10 is going to be difficult, and let me share a study with you that was done by the advisory board. They looked at ICD-10 and the transition that was seen in Canada, particularly focusing on the ongoing costs. What are some of the things that people are not looking at that they'll see after the conversion date? Right? Those are the larger costs, the recurring productivity hits. And look what they put front and center. A 10 to 20% decrease in physician productivity. If you want to get underneath those numbers and understand what was happening when Canada transitioned to ICD-10, they had coders coding from the documentation. And they would have to go back to the physician and ask the follow-up questions back to the provider to say, can you be more specific about this? Can you tell me about the stage of the diagnosis? I need you to be more specific about which eye it was in. I need you to tell me more about the etiology of the problem. And that was taking, on average, per provider, 45 minutes per doctor per day. And in a busy ophthalmology practice, even if you cut those numbers in half, where are you going to find an extra 22 to 45 minutes per provider per day? We can't ask them to see fewer patients. And they cannot spend that time at the end of the day answering follow-up coding questions rather than spending time with their families. Neither of those are acceptable outcomes. That's why we have to protect against this. We're going to spend a lot of our time there, because if you don't get that piece of it right, the rest of it doesn't matter. But let's talk about the coder productivity, the rework productivity as well. What you'll see on the far left-hand side of the screen, the coder productivity declines significantly in the first year. Now, they will regain some of that as they get up the learning curve, as they get more familiar with ICD-10. But they never get back to current productivity levels. That permanent 5 to 10% decrease in their productivity, it's not their fault. It's just that ICD-10 is more complicated than ICD-9. So what we want to do is, can you put tools in place? Can you put resources in place? Can you put processes in place to make them more efficient so you don't have to hire additional employees? And look at the far right-hand side of the screen. You see an increase in the rework that has to be done because of denials, inquiries, adjustments coming from the payers. You look at the early end-to-end testing results coming from Medicare, and it looks like denials are doubling or tripling as a result of ICD-10. So if your denial rate is 2 to 3% today, it could be as high as 4 or 9% in ICD-10. You cannot control the payers, right? You can control your internal process. You can make sure that you're on the low end of that range. You want to do everything that you can to be prepared for that. And we're going to talk about some strategies of how to make sure that you're prepared for what's coming in the fall. But we don't want to be all doom and gloom. ICD-10 is not as hard as a lot of people make it out to be. There are some common myths that are out there about ICD-10, and I want to dispel just a few of those quickly. One of the things you hear a lot of people say, talking about all the new codes in ICD-10, 69,000 codes in ICD-10 compared to only 16,000 in ICD-9. And that's true. But what most people don't tell you is you don't use all of those codes. Most ophthalmology practices use less than 2% of the entire code set in ICD-9. And you're only going to use a small percentage in ICD-10 as well. Don't worry about all the codes you're not going to use. Let's focus on the codes that you will use. You know, another thing that fearmongers like to talk about are some of the crazy, ridiculous codes in ICD-10. And they use these as examples to say ICD-10 is ridiculous. You could never do this successfully. The level of detail required is so unbelievable. You shouldn't even try, right? And probably the most infamous ICD-10 code that people like to make fun of is this one, V91.07XD. This flaming water skis encounter. Yes, that's a valid ICD-10 code, and yes, it can make for some funny pictures and that sort of thing. But what most people don't tell you is that code already exists in ICD-9. It exists today. It's E837.4. And you never use it. You never use that code, and you won't use that code in ICD-10. It serves as a distraction. A lot of these codes that people like to make fun of are E codes in ICD-9, external cause codes, and Medicare has already come out and said, if you are not using external cause codes today, there is no new national mandate to use those external cause codes in ICD-10 either. And so a lot of people get worried, get nervous about the new crazy codes, but the truth is that they're never going to use them. And the truth is it distracts them from looking at the codes that they do use today, some of which are going to be silent killers when we get to ICD-10, and I'm talking about unspecified codes. It's a dirty little secret. Everybody knows unspecified codes exist in ICD-9, and they exist in ICD-10. Now, a lot of people use them in ICD-9 because they use them as a catch-all. They use it because it saves space on their paper super bill. They use it because it makes their EHR template easier for the doctor. They use it because it's the only code that matches up with their documentation. There are many reasons why people use unspecified codes today in ICD-9, but regardless of the reason, unspecified codes are typically payable diagnoses in ICD-9. There are no negative consequences to using them, but that won't be true in ICD-10. In ICD-10, there is significant risk to using an unspecified code, and there are two real risks. One's a short-term risk, and one is a longer-term risk. Let me talk briefly about both. The short-term risk to using unspecified codes in ICD-10 is that the claim won't get paid. Now, this may not happen on October 1st. You may not see this for several months for certain payers. It may be the first 12 months for carriers like Medicare. But you will see this in the short term. The claim will get denied if you use an unspecified code or certain unspecified codes. And here's the reason why. Think about it from a big picture perspective. The reason the payers want to move to ICD-10, the reason they've made the investments in their infrastructure and architecture, the reason they have lobbied to keep the ICD-10 date as it is because they want the more detailed diagnosis information. They want the more granular diagnosis codes on their patient population so that they can use that data over the long haul to drive down healthcare expenses. That's what the federal government wants. That's what the payers want. And if the provider community does not give them that level of detail, they are going to deny the claim. That's the short-term risk. The long-term risk is we are obviously transitioning away from fee-for-service, moving towards an outcomes-based reimbursement model. Pay for quality, pay for performance, pay for outcomes. And in that world, it is all about the expected outcome compared to the actual outcome for the patient. You know, how sick is that patient? What are the comorbidities? How acute are their diagnoses? And you need the more specific ICD-10 codes to show how sick your patients are. You need to be able to do that to maintain and maximize your reimbursement. And if you use the unspecified codes, you're going to be on the end of the spectrum that is having reductions in their reimbursement rates. That's the concern. Those are the risks to using the unspecified codes in ICD-10. And you want to start off on the right foot with that. You want to start off on the right foot. So don't focus on the codes that you'll never use. Don't worry about all the codes that are for other specialties or some of these external cause codes that you're not using today. Let's focus on the codes that you do use. And let me show you how to do that. We've done this for our client base. Take all of their ICD-9 codes that they use, and you can get this from a frequency report out of your practice management system. You can usually get it off of your paper super bill if you're using one of those. But most practices fit somewhere in between 200 and 300 ICD-9 codes that cover the majority of their patient encounters. When you take that and convert it into ICD-10 codes, what you'll see are two things. Number one, everybody has a significant increase. Number two, orthopedics is by far the worst. Thank goodness you're not in orthopedics, right? We also go a step further because not all codes are converted equally. So we put them into different risk categories: low risk, moderate risk, and high risk. Let me explain what those mean. I'll show you examples of each. The low risk ICD-9 codes are those that can be translated directly to one ICD-10 code. Everybody loves those. Those are great. Unfortunately, for most ophthalmology practices, it's typically between 25 and 30% of your codes that fit into that category. The others are in the moderate and high risk. The moderate risk ICD-9 codes have between 2 and 10 choices in ICD-10 for each ICD-9 code. The high risk are those that have 11 or more choices. Okay? So when you look at this, it's a good place to start, and what we recommend doing is doing this conversion analysis if you have not already. And let me show you just a quick sample of what that looks like. This is one that we did for a client of ours, and you can see up at the top the numbers in red is that summary data that we saw on the previous slide. But it goes further than that. If you look down towards the middle of the screen, you'll see where you start to get the line-by-line detail. So look at 368.2, diplopia. One code in ICD-9, you can see that's one code in ICD-10, and it also shows you the new code and the new description, H53.2, diplopia. That's one of the easy ones, right? And then you can see, if you look at the next one down, the one shaded in white, for a conjunctival hemorrhage, 372.72, 4 codes in ICD-10. One for the left eye, the right eye. There's a code for bilateral conjunctival hemorrhage. But there's also, if you look at the first result, there's also a code for an unspecified eye. That's a valid ICD-10 code, but it may not be a code that you want to use. When you look at this, it's a valid code. You can look it up in the code book, but what are your payers going to do if you bill for a face-to-face encounter with the patient, but you didn't know which eye the conjunctival hemorrhage was in? Are they going to pay that claim? Are they going to pay that at 100%? That's the concern. And then you look down at the next one for low-tension glaucoma, and you can see there are 20 choices. You need to be more specific about the stage as well as which eye. And I show this to you for 2 reasons. Number one, I think it's helpful for you to share this type of information with your staff, helpful to share this type of information with your providers, because it relieves some of the anxiety about ICD-10. Yes, it's a significant increase in the number of codes, but when you look at the new concepts, they're relatively straightforward, right? Those are not foreign concepts to your clinical staff. It makes ICD-10 seem a lot more possible for them, and they can get on board with a plan to move forward successfully for ICD-10. But the other thing that it does is I think it helps point out that the status quo won't work. You can't have the same process in place when you have 1,400 diagnosis codes that you did when you were using 300 ICD-9 codes. That's the concern. And so what I recommended for people who attend one of our webinars, we'll do this ICD-10 conversion analysis for you at no charge. It's a free service that we offer for people who attend one of our webinars. If you'd like to get that information, use the question it has the CPT codes on the front, it has the diagnosis codes on the back. Now what really caught my attention is they also have an ICD-10 version. The ICD-10 version looks like this. The front side stays the same, but the back side is 8 pages long. Now that may be ICD-10 compliant, right? They're all valid ICD-10 codes, they're all there, but it's not productive. It doesn't match up with your workflow. That couldn't be used in the practice today. Can you imagine trying to put that in the hands of one of your providers? And I use that as an example to say this is what you need to think about. Think about how your workflow is going to work so that you've got ICD-10 productive solutions in place for your staff and for your providers. All right, let's think through this a bit more. You know, you can't do an 8-page super bill and you can't do a jumbo super bill, right? That won't work. 8.5 by 11 inches on a piece of paper, you can't list out all of the codes on that form today. Now, for many of you, that may not be what your current process looks like. You may not list out diagnosis codes. You may have doctors that are writing in a description. You may have coders that are coding from the documentation. You may have doctors that are doing this in their EHR. But you need to think about it's not just the codes that are changing. It's the descriptions. It's the coding concepts. Those are changing as well. And when you start to think about your workflow, you start to think about your process, right? If you're using a paper super bill like this today, or if you're doing it some other way, you need to think about, how am I doing that today? What makes that so successful for us? And how is that going to work in ICD-10? So you think about this process. We did a national survey last year. Why do 54% of practices still use a paper charge ticket, a paper encounter form? It's because it's so fast and easy for the provider. They know where the codes are on the page. They can probably fill that out with their eyes closed. You have to understand what makes that successful today before you can make sure you have the right solution, right? Fit the solution to your workflow, not vice versa. So what do we see other ophthalmology practices doing today to handle this? I'm going to walk through 3 different options. The first, I see this more commonly in hospitals than I do in practices, but I want to walk through it anyway because it is a viable option for some groups, and that's to hire certified coders to do this work. You get your doctors to go through CDI, you do all the documentation, make sure that they do it well, coders will code from that. Typically works in the hospital setting because they have more money. But breaks down into practice because coders are expensive, they're getting more expensive. At the same time, they're getting less productive. It's kind of a double whammy from an ROI perspective. If they're getting more expensive and less productive, the economics of that get worse, not better in ICD-10. So I see more people doing option 2 or 3. Okay, now option 2, and I realize this may be easier for me to say than for you to do, but it's just get all your doctors to use the EHR or use it correctly, right? And when you talk to practices that struggle with this, it's typically not because their doctors are non-compliant or because their doctors hate technology. It's typically because their doctors are worried about their productivity. It slows them down, right? And the challenge for administrators and project managers is that if you face that struggle today, it's going to get worse, not better, with ICD-10. And that, again, that's not your vendor's fault. ICD-10 is more complicated. ICD-10 is more difficult. And the way that most EHR vendors, this is why if you're going to consider this option, you need to understand how it works. Because the way that most EHR vendors have solved it is through a code search process. You know, it's really easy to put 69,000 codes in a database, and you search for the codes, you see the results, and you make your selection. That sounds really great. That sounds like it would work just like Google. But that's not the way it works when you're searching for a diagnosis code. If you search for diabetes and you get 50 search results, when you search on Google, 99% of the time the answer of what you're looking for is number 1 or number 2 on the list. You know, that's why everybody tries to do SEO to get their web page at the top of the Google search results. That's not the way it works in diagnosis code search. When we search for diabetes and get those 50 results, you'd have to read through all of the 50 choices to choose the one that's most accurate for that particular patient. Or maybe you have to drill down through a decision tree to get to the right diagnosis code. Answer a series of questions in that system. And you still have to ask yourself, what are the chances that my doctor is going to pick one of the unspecified codes that we don't want to use? Most of the time when you look at code search results, you'll see an unspecified code at the top of the list because it's sorted in code order. If your doctors are like everybody else, they've been trained by Google to expect the search result to be at the top of the list. you may be often using an unspecified code for one of those unspecified eyes, like we talked about before. So the third option, and I'm certainly biased, but I think this is the best solution for a busy ophthalmology practice, is to use an electronic superbill, because it can be designed in a way that protects the doctor's muscle memory, made to look like the paper superbill. That cuts down on the amount of training time required. It also makes it very fast for them to use when they're in a production environment. But at the same time, making sure we get the billing team the right code the first time so that the claim can get paid correctly and completely the first time. Now again, if you're a visual learner, let me show you just an example of how that works, what that looks like. This is AcceloCapture. It's an electronic superbill. This is just one example of how it was customized for one particular practice. We typically recommend making the electronic superbill look just like the paper superbill does today. Put the codes in the same place. Now I'm going to go through and do one encounter in ICD-9, and then we'll do the exact same encounter again in ICD-10. So if I've got a level 3 office visit with a visual fields test, and then I flip over to the back side and I've got a couple of diagnoses, right? I'll use the same examples that we looked at before. Diplopia, conjunctival hemorrhage, and then we'll do low tension glaucoma. Pretty fast, pretty easy for me in ICD-9. Okay, now let's do that exact same example, but this time we're going to do it in ICD-10. And here's what I want you to think about. Pretend that I'm one of your providers. I haven't come to any of the ICD-10 training classes. I'm walking in, it's Thursday morning, October the 1st, and I'm about to see my first patient. Let's see how I do. The front side stays the same, right? No changes to the CPT codes. Great. Let's look at the back side. Is it 8 pages long? No. It looks exactly like it did the day before. The doctor's muscle memory is still intact. There's been no change yet. Great. We love no change. Let's come down here and click on diplopia. This is the first time that you'll see a change. Instead of it being highlighted in yellow, it's highlighted in green. This is a visual cue to the user to let them know that something's different. It's been converted automatically into ICD-10. It's got the new ICD-10 code, the new ICD-10 description in there, but as a provider, I didn't have to do anything different. I love those. Now again, for most ophthalmology groups, that's only 25 to 30% of the codes that are most frequently used in the practice that can be converted like that. So let's look at a more complicated example like conjunctival hemorrhage. When I click on conjunctival hemorrhage, what you'll see is that it cannot convert that for me automatically. So it gives me a pop-up and shows me my choices. Left eye, right eye, both eyes. Now you'll notice that it does have that option in there for that mysterious unspecified eye. And this is where coding is part art, part science. There are places where reasonable people can disagree. Most of our practices are choosing not to show their doctor the choice for the unspecified eye. They don't want to use that code. There's a configuration setting that says take that option off, don't show it to them. We only want them to use one of the 3 choices for left eye, right eye, bilateral. If it's in the right eye, all I have to do, one extra click, it closes that pop-up for me automatically, puts in the new ICD-10 code, the new ICD-10 description, and I'm done. Great. Great. What about something that's even harder? What about low tension glaucoma? When I click on this one, what you'll see is that it gives me that pop-up again, but this time, since there are 20 choices, it's organized it for me into 2 dimensions. It has the diagnosis stage on the vertical axis. So you can right eye. Now, in many places, I'm sure your providers are already documenting at this level of specificity. This just serves as a helpful reminder of where they need to be more specific. All right, so again, remember, we're trying to make ICD-10 a non-event for your provider. We're trying to make that easy for them. But also at the same time, we want to provide the billing team with all the data that they need to get the claim paid the first time. Now, I know we've spent a lot of time talking about the providers. Let me spend the next 5 minutes talking about the revenue cycle, and then I'll open it up for questions. Because it is a big change for the billing team. And it's not just a one-day change for them. They're going to have to deal with the changes that continue to come in the months and years following ICD-10. You know, think about the reimbursement process at a very high level. In the fee-for-service world that we're still operating in, you get paid for CPT codes, but you have to have a diagnosis code that makes it medically necessary. That's true in ICD-9. That's true in ICD-10. But it's not that simple. It's not that easy. You still have to make sure that you jump through the hoops and hurdles that the payers put out there to get the claims paid. And on top of that, not all payers want that done the exact same way. Blue Cross wants it one way, Medicare wants it another way. You probably have people in your office who know that well, who have that information in their head because they've been doing it for years. But the problem is that head knowledge, that process, will go out the door on October 1st. The cat and mouse game is going to continue, but the rules of the game will change. And remember, the payers have never done this before either. This is new territory for them as well. They're going to be making adjustments, and they're not going to all do that the same way. So what that means is we're going to have a high change environment. The rules of the game will change, and will change very, very quickly compared to what we've seen thus far in our careers. The volume of change will be very, very high. So what we have to ask ourselves is, if that's the environment we're going to be in October and November and December into the first quarter of next year, what types of tools and what types of processes are you going to need to have in place to be prepared for that? Who on your staff is going to manage that, right? And maybe the scarier question is, what happens if we don't do a good job of that? Okay, this is going to be a marathon, not a sprint for your revenue cycle. And if you're going to run a marathon starting in October, the best thing that you can do is start getting in shape today. Get your denial rate as low as possible. Get your process for dealing with denied claims in as best shape as possible. We call this closed-loop denial prevention. Anybody can do this. You know, we recommend this to all of our clients. And we provide them software that helps with this. But you don't have to have software to do this. It helps, but you don't have to have software to do it. But software to help you is like having a trainer helping you prepare for a marathon rather than just running on your own. It says, I can't eliminate denied claims. I can't rid the world of denied claims. But here's what I can do. When I see a new denial, when I see a new policy, I'm going to go through this process. I'm going to go back to the beginning, understand what went wrong, and figure out how to build in a new rule to make sure that it doesn't happen again. You know, that way, when the exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months from now, that rule is going to fire the exact same way for all of my employees, whether it's my most senior certified coder or my newest billing clerk. They both get the same actionable information at the right point in the revenue cycle to prevent that denial from ever happening again. I can't control the payers, but what I can control is my own internal process. And if you can do that, if you can get in good shape prior to October 1st, you'll be better prepared to be productive in an ICD-10 world. And this is the last slide, and then I'll try to answer the questions that you might have. What I want you to think about is, what do you want your practice to look like in October of this year? What do you want your practice to look like in November of this year. Think about your providers. Think about your billing team. Think about your waiting room. Is the goal just to be able to submit claims that have ICD-10 codes on them? Or is the goal to make sure that you've understood all of the changes for your practice and that you've optimized your workflow for the new world that is coming? Are my providers, are we going to be able to protect their time, or are they going to be staying after hours to answer those follow-up coding questions? That's not what they got into medicine to do. That's not what they enjoy doing. That's not what they're best at. They want to be able to remain focused on their patients, not on coding. And your patients expect the same thing. Your patients aren't thinking about ICD-10. They're going to expect the same high-quality service and patient care that they get today. And what about your billing team? Are they going to be working nights and weekends trying to get claims out the door? Managing that back and forth follow-up process with the provider? Or are we going to make sure that they're equipped to get the right information the first time so they can do their job and do their job timely? Are they going to have the types of tools and resources they need to be able to keep up with the changes coming from the payers? Or are we going to have to outsource some of our follow-up work or hire additional employees to do that? That's the big challenge. There's no additional revenue for ICD-10. It's not an incentive program. And if there's no additional revenue and you have to hire additional staff, that means the practice is going to be less profitable. And unfortunately, a lot of people won't see this coming. They're going to respond to it after the fact. If you can get out ahead of this, it doesn't have to be this way. There may be places where you can be more efficient, where you can be more profitable, and you can thrive during the transition to ICD-10. You know, rather than this being another government program that makes the practice of medicine more difficult. All right, now I know I went through a lot of information, and I covered that quickly, but I hope that it was helpful for you. What I'm going to do is I'll go ahead and try to answer as many of the questions as I can. But thank you again for your time today. We really